All right, this may be overdoing it, but feels like in the morning, at least if you're in Geneva in the Central or West Africa, it is morning and it is time to kick off this course. Of course, I'll be facilitating together with Charlotte, and we're pleased to have, of course, colleagues from WHO and UNICEF who've been sharing their subject matter expertise and supporting those of you who've been making your way through the course. We're going to go very quickly because the main point of today's session, you can see there's 20 minutes for an overview of what participants have achieved in a week. Well, you know what you've achieved, you've done it. And so we're going to jump into participant presentations where we really want to give as many people as we can the opportunity to present their work, their action plan. Remember, this is not the final action plan, so I'm going to quickly run through what you need to do to actually finish the course. It may feel you may already have a sense of completion, of achievement, and that is well deserved, but you can see here the 5 things you need to consider before you are going to be sure that you actually finish the course. So first of all, attendance in this session is required for certification. Second, you are going to be asked to present your action plan, so please prepare to share your screen. Make sure your microphone is working properly. You've all had many opportunities to test that. And in addition to presenting your plan in response to very specific questions, we'll also ask you to share what you've learned by performing to peer review. It's too early to ask you what you learned from the peer reviews you received because you received them at midnight last night. But it is, we want to know when you do peer review, it is also a learning process. So we will be asking you about that. Now, just because you submitted a plan and submitted 3 peer reviews does not mean you'll earn certification. We'll be looking at your work before making that decision. And then your final task this week, and this is critical, we always have 1 or 2 people who are super diligent, who do everything they're expected to do in the course, and then they somehow miss that you're supposed to take, what you need to do is take your initial action plan, which is a draft, and take everything you learn throughout the course, starting with your peer review feedback. But in some cases, you may consider that your peer review feedback isn't actually helpful. Whatever the case may be, you use everything you've got and you identify specific things that you can do to improve your action plan. And then the improved version of that is due on Friday. The presentation of your action plan against very specific questions. So I'm going to, let me just see, where is that? Yeah. I'm going to paste that into the chat if Charlotte hasn't done it already. And so don't forget to tell us who you are, where you work, what country. Be concise and get to the point. We realize it's difficult. You've been working so hard on this plan. You've been working so hard on peer review, but we will mute your microphone after 5 minutes, and you're responsible for keeping time. So do not be surprised. We really want as many people as possible to be able to present today. And you can see there are 5 points in your presentation. First is diagnosis. What was your priority group? What knowledge gaps did you identify? What are the top drivers and barriers to vaccination for this group? Remember, you have to do this in 5 minutes, so don't tell us everything about your priority group. Don't ramble about the knowledge gaps or go through all the drivers. Just get to the point. The top 3 factors that can facilitate uptake of vaccines, and why these factors, why you think these are important. For implement, we'll just ask you to summarize, tell us what actions you want to take, and the most important thing is why you think these are the actions to take. Evaluate, tell us what, if you carry out these actions, what's going to be different. And then this speaks to the sort of more holistic learning that you've been doing through the course. What are you going to improve in your plan by Friday? So we want a specific example of a change you're going to make and explain why this is an improvement. A final point before we kick off before we go into the presentations, and please be ready, raise your hand if you'd like to be the very first presenter today. If you are listening to the presentations, remember, you honor the work of your colleagues by taking time to listen. Now, if you have to multitask and keep one ear open to the presentations, well, we will live with that. But what we'd really appreciate, and what I think your colleagues will really appreciate, is if you share your comments about the presentation in the chat. So that can start with praise. If you think it's a good presentation, please say so. But we know you have been thinking intensely about your own situation. Through peer review, you've engaged with the work of others. So we know you can help, share your insights, share your comments, and raise your hand if you have something that you would rather say or ask orally. It would be lovely to get some dialogue here. And of course, once we've asked participants, we'll turn to our WHO and UNICEF global colleagues for feedback. One final reminder about the rules for fairness on speaking in the course with respect to the raised hands. You can see the rules here. You've seen them before. So I think, Charlotte, that's it. Have I forgotten anything?
No, Rada, I think it's quite complete. So we would just want to invite scholars to raise their hands and start presenting the action plan.
All right, I see Juliana Adukuchili Kudu is going to be our first presenter. Juliana, warm welcome to you. I hope your microphone is working. Can you hear us?
Yes, good morning.
Okay, wonderful. Would you like to share your screen? Yes, you would. Okay.
Yes, I'm sharing my screen.
All right.
Just a minute. Can you see my screen?
Yes, we can.
Okay, a quick one. I'm Juliana Kudu from WHO Nigeria, Gombe State Field Office. So I'm actually looking at the impact of poor community mobilization on vaccine utilization. And it's basically this action plan is trying to look between access and utilization. Access is good, which is a plus, but when it comes to utilization, there's usually high dropout rate, meaning mothers will bring their wards for vaccination at the early stage, but they don't get to complete it. And one of the major reasons that has been seen is because of the mindset, or rather the effect of the Penta-3 vaccine, because I'm looking at utilization. So I'm putting Penta-3 into consideration. And usually they tell you it's so painful, and that's why they don't go back to access it. And why it's so, it's because the community is not properly mobilized using the proper linking group, which is the VDC. And so I'm trying to look at, this study is trying to look at the role of the VDC in terms of improving this utilization. If the VDC is in place and is functional, then definitely it will link the services more better to the community, because it is there that the VDC members will be sensitized. And when they are sensitized, they will also in turn sensitize the mothers and caregivers. And so the issue of AEFI will be taken care of. So, and I'm also looking at the evaluation, how to evaluate, monitor and evaluate, is to look at the number of, or the proportion of the real micro plan that will be updated. And this, in the process of updating the real micro plan, it has to do with the community, with the involvement of the community. The community has to own the program. And so when the community is fully in participation in the services, then of course ownership will take place. And when ownership takes place, then there will definitely be an improvement on the utilization. That's one of the indicators. And then the second indicator I'll be looking at is the proportion of unvaccinated children at the end of the implementation phase. How many of them are actually vaccinated? And this will be done by way of follow-up during in tracking the status of vaccination. And then frequency of feedback meetings held with the VDC. There has to be these routine meetings with the VDC to share feedback, to know if the implementation phase or the action put in place, it's really yielding results or not. So basically, this is what is contained in my action plan, even though from the peer review, I've gotten some insights as to how to improve on my action plan, which I'm going to do that immediately after the session. I'll work on it and improve on it before the final submission. Thank you.
Thank you, Juliana. You are our first presenter, so let's offer a round of applause, even if you are alone in front of your computer screen. Please.
Hey,
thank you.
Bring your hands together. Now, I do have some questions for you, and then we'll look at what questions asked by participants, and then we'll turn to Francine Genter-Restrepo from the World Health Organization for feedback. So can you tell us what are the top 3 factors in your priority group that can facilitate uptake of vaccines for this priority group, and why these factors are important in your view?
Okay, the top 3 factors are looking at the functionality of the VDC, because it is the VDC that will link the services to the community. Then I'm looking at sensitization during the sessions, and then tracking, which is going to be done during home visits and also during defaulter tracking.
And can you summarize for me just what actions are you going to take and why?
Okay, basically the action is to conduct advocacy visits to the key stakeholders and influential persons within the community. And it's necessary because without the community being involved, whatever the health service provider plans for the community, it will definitely not yield results. And so it is very necessary for the community to also participate, and that is why that action is going to take place.
And so how do you imagine what success looks like? Like if you carry out these activities, what is going to be different?
What is going to be different is the utilization is going to improve by way of evaluating the number of unvaccinated or the dropout rate. The dropout rate, of course, at the end of the day should be lower than what it used to be, or it should be within the acceptable level.
Okay, and then my final question is, so it's too early. You said you looked at your peer review feedback and saw some things that you think are going to be useful, but what did you learn by peer reviewing the works of others? Can you give us an example of something you learned?
Okay, like the first work I reviewed, I got to realize that there was a gap in mine, which the first work I reviewed actually gave me a pointer to. And in my own design, I didn't elaborate more on what the problem is by linking it to a story. But I now saw it in the first work that I reviewed. And many other things that I also discovered in that review.
Okay, thank you. And you have right now only one comment from your colleagues. I know that you have been working together, so please, Juliana obviously has put a significant amount of work, of effort into the action plan which she just presented. So do share your feedback in the chat, and then we'll pick from those of you in the chat. We may invite you to speak. Dr. Iwat Ndayo says, Juliana, thank you so much. VHC is a community managerial structure for PHC and immunization services delivery. So let's go to Dr. Iwat. Oh, and he's gone from the room, unfortunately. All right, let's go now to Francine Genter-Restrepo. Francine, we would love to hear your feedback after this short presentation.
Yes, thank you so much, Reda, and thank you for this wonderful presentation. It's great to see the emphasis on community-centered design and thinking there. I really like what you said a moment ago about if the community is not involved, then the plans are just not going to be viable. So it's great to see you prioritizing that. I think my feedback would be to, it sounds like there might be a little added diagnosis that could take place there to really understand specifically what are the barriers for the community in question, and then with like really granular idea of what are the barriers that we can address, go on from there to more concretely spell out the design the specific things that the micro plan will try to take into account and how we'll be measuring that. But I absolutely love the use of standardized immunization data in your indicators. I think there's just that need to be a little bit more specific in terms of the access barriers that you're referring to, that you'd like to address, and how that's going to take place. The sensitization, the involvement of the community, really important. But as I said, the more work we do in the diagnosis, the better we understand really what the challenges are, not just the barriers, but also what drives vaccine uptake, what motivates people to go get vaccinated, and the easier the subsequent steps become, so that we can pull that thread. I've been saying this on separate sessions as well over the last couple of days, but it should be this clear thread across all those stages, starting from the diagnosis, we weave into design, implement, and then evaluate. But I really want to congratulate you on a job well done, and you've really understood the ethos of the Closing Gaps tool to put people at the center of planning and put their needs, their perspectives first. So really, well done. This is marvelous to see. Thank you.
Thank you very much indeed, Francine. One final question for Juliana comes from Mohammed Nasir Umar, who says, what are other factors that can be useful in looking at the functionality of community engagement strategy activities? What are your plans? He wants to know to engage the husbands and grandparents to improve acceptance. Juliana, is that something you're considered the different sort of subgroups, and in particular husbands and grandparents?
Yes, that will be done looking at focus group discussions with focus groups within the community.
All right, wonderful. Okay, so now, thank you once again for being the very first presenter. I see, is it strange? There's only one hand raised, so we are going to go to Zosimo. Remember, we will call on you to present if you have not done so already. Zosimo?
Thank you very much. Good morning.
Now, before you start, Zosimo, please keep in mind the specific questions. I'm going to paste them in the chat. And remember that we will mute your microphone after 5 minutes. Please go ahead and share your screen if you'd like to show your plan. That is up to you.
Thank you very much. I'm working on here we have action plan strengthen demand for and uptake of vaccination. Here I was showing some figures. It is a kind of PowerPoint presentation. What is really the problem? The problem is under the vaccination under 5 years suffering from vaccine preventable disease in Africa. Case study of Chad, where the uptake are on 58 in 2021, and about COVID they are on 0.8 of population full vaccination. The group it is fragile people on Sahel and Horn of Africa remain invisible or 12 system missing life-saving vaccination as a consequence. Population moving across porous border because they are nomadic by nature, or they have displaced by conflict or other natural disaster. Means that the population are zero-dose children or marginalized population and the vulnerable group. Here we have some top driver where how strengthen immunization program as an integrated component of primary health care and universal health care. Strengthen human resource capacity for health, mobilizing political commitment, investing in at national capacity, empowering individual and community. On the top factor that can facilitate uptake of vaccine is the people-centered approach, is the country-owned, is the like equity, data driver, sustainability, innovation, and technology. Why is it this the people-centered approach, country-owned equity is the best? Why are they important? Because people-centered approach, where we consider end user to participate in designing and implement and giving feedback on the program where we are working with the community. Country-owned is it the country to be sure to see how to manage well the vaccination. Equity is the access, no behind is the access, to give access for each children or for population in a life course. Where if, for example, innovation and technology, where we can use GIS or drone for giving vaccination for population where are too hard to reach in this kind of equity. About implementation.
1 minute.
Implementation is increasing immunization coverage, sustaining, preventing and control other vaccine preventable disease. About here we have some activity to overcome, like to increase immunization coverage and equity, to prevent and control other vaccine. We have the indicators. Indicators is to achieve, indicator 1, to achieve at a coverage rate for all vaccine at the national level. You see the purpose is the increasing immunization coverage and equity. The last one is the indicators are set according to percentage and how the purpose and short, if it is at short or long term, the frequency is monthly, quarterly, annual. The means of verification and correction is the DHS2 electronic immunization register, and the responsible is a country working group and the regional committee or district management team. Thank you very much.
All right. Thank you very much indeed. That was, I realized that was, you had to go really fast. Let's go for this presentation. I suggest we start with Francine's feedback and comments. Knowing that
yes,
we have the point of the presentations today is to really give you some guidance and feedback as you work to improve and revise your plan by Friday. Francine?
Thank you, Rita. And I want to say thank you to Zosimo for this presentation. You have an extremely, extremely ambitious plan there, which is wonderful. It's wonderful to see. I think my recommendation to you would be to really, again, just be much more specific and narrow that down. You know, it's very easy when we do this to get carried away and say, you know, we want to get everybody vaccinated and save the world. But it's helpful to think about the good enough principles that are in the guide, and be okay with taking the small actions, the achievable and realistic actions that we can achieve, and really thinking about the resources in that setting. And this is why I said about the last presentation as well. The stronger our diagnosis is, the more specific we are. If we can narrow down to a specific community that we want to focus on, where the uptake is especially low, it helps us then to frame the subsequent actions in ways that are really more practical and more achievable, and it helps us embrace this idea of good enough. And I also want to say that these little actions, they have sort of an echo through a system, right? It inspires program-wide change. So don't be afraid. Don't be afraid to be more specific, more granular, and really zone in on a specific community. It's okay if we're not addressing the national coverage. It's okay if we're focusing on even a village. That would be my recommendation there. But thank you so much, Zosimo. It's really lovely to see your presentation. And I have to say, just really well laid out and presented. So thank you for that.
Thank you, Francine. We also have Mudo Messina from WHO. So it'd be lovely, Mudo. I don't know at what point you were able to enter the room, but to hear some initial feedback from you on this on the presentation we just heard.
Thank you, Rita. Sorry, I just joined a little bit, I think, late on this presentation, so I will just rely upon my colleagues' comments, and then
Okay. Understood. Yeah. Thank you, Mudo. And I think there's a very important comment from Dr. Mohamed Bono, so as a peer, who responds and says, thank you, Zosimo, for the detailed work. And Dr. Bonos recommends that you focus on a particular population community rather than on the whole African continent. He says that to me looks huge and ambitious, as Francine also pointed out. All right, wonderful. We have now Maria Fernanda Monzon, who's our next speaker. And again, you have 5 minutes to present. I know you want to present your entire plan, but due to the lack of time, I've put specific questions that have been up on the screen since the beginning of this session. Maria, a warm welcome to you. I know it is very early morning for you, as you are in Latin America. So please, I'm glad that you're able to present right away.
Hi, good morning to all. Thank you. Yeah, joining 5:30 in the morning here in Argentina, but happy to be with all of you. So, well, I'm a pediatrician. I'm the director of a primary healthcare center, and this action plan is centered in Costa Esperanza slum that is about 500 meters away from the health center. So you can see my screen, right?
Yes.
Well, to diagnose the drivers and the barriers in stage 1, we are talking the chosen population is babies from 0 to 6 months old that reside in this slum, that are being missed out of the regular vaccinations that are mandatory and free. So the tracer vaccines, BCG coverage is 67%, and IPV, the third dose, which is mandatory at 6 months old, and the pentavalent is 83%. So this is a slum that has about 500 homes with a high density population. Like every slum, they lack drinking water, sewages, they have precarious housing, and by the national information, we have that 25% of children, so 1 of every 4 are poor. School attendance is high, which we cannot take as something that we can leverage on, because we're talking about children that are older. And this actually helps us because parents, 61% of the parents actually have a high school degree. So it's not an illiterate population. The challenge is present because the universal assignation per child, which is a government aid, monetary aid, is most of the times the only income in the household. But this, you need to collect this money, you need to present on an yearly basis paperwork, which includes vaccination coverage, the paperwork, the calendar. Here is a bit of, to show you that in 2020, there were less than 200 cases of TB in Corrientes, no cases of meningitis TB, only 1 case of tetanus, There are no deaths from diphtheria or tetanus in children under 5, only 2 deaths in the whole country by pertussis. So all these VPD are not at all frequent. And these are the ones that are prevented with the vaccines that I want to target. So the challenge is present because parents on one side are not, it's not mandatory for them to attend the healthcare center to receive the vaccines because the paperwork needed to keep receiving their assignments, their monetary aid, is only due once a year, and it's presented when they are born. So during a full year, they're not obliged to go to the health center. And on the other side, there's no immediate perceived risk to get sick, as the population does not have the VPD frequently presented, which is good because we actually used to have better coverages. So the lack of community engagement is because there's no confidence in the vaccine benefits, because there's no sense that they need to prevent them, because there's no incidence really in the general population. Before, there used to be a milk national program, which was that they would attend the health center to collect milk every month, and then we would take advantage and get them vaccinated. The main thing in the diagnosis is that all this information has been extrapolated, so I really need a specific survey from this population. What was gathered here was about how I could get it with the general information from the province and from surveys to the healthcare center staff, like the nurses and the health community agents. These are some maps that show the how was the potable water net, the sewages net in this slum. In the design, we're being centered that we have to address the confidence in vaccine benefits. So there was some description of the end user persona as this mother that has a baby, and she really sees no benefit in receiving the vaccines, as there's nothing in exchange. I cannot give them milk. She doesn't give, paid better or anything if she comes to get the vaccine. And the practical issues, I think one of the factors that we can work on is that we are on a walking distance to the slum. So there's not an access barrier. They do not have to take any public transportation. It's free of charge. And it used to work well when we were actually giving something in return. The next step is the educational campaign to inform the people about the vaccination with an approach that is based in the community. This will be successful, or it's likely to be successful, because we can use the resources that are already available in the primary healthcare room with the staff, and then the community is open to listen. They are a community that welcomes people that want to work with them, and we cannot rely on something that can imply that we have to bring money from outside, like buying, for example, this milk, even though that was something that worked out. In the implementation of the educational campaign, we have 2 interventions. On one side, the training for the healthcare workers, and the community plenary, with the training is to update the nurses and the community health agents. And there are different learning activities that I had put in place, or I'm planning on putting in place. And the community plenary is, it would be held in the PHC room, and participants, we will start with 20 caregivers and see if we can work with them, and then keep tailoring to the rest. So also I had presented some learning activities that are described in the action plan on how we can work with them, and then how to measure with short, mid, and long-term indicators, number of people that will participate in this plenary, how many of them have incomplete calendars, how many of the healthcare workers have I trained, percentage of caregivers, that have reported the acceptability. In long term, the vaccine coverage, how has it increased? How many of these caregivers are satisfied? And how many of the VPD have been presented, in the slum, how many cases? And well, more information about the indicators. And it's important to do a field test and to, with that feedback, keep on using, tailoring the session. And the evaluation stage, I have described the indicators and what was the purpose of 6 of them that are the main ones that I believe will take us to 7, to tailor the implementation, this intervention. And I believe it can be successful because it's planned on resources that are available. It's tailored to a specific small community, and it's an educational campaign that can be taken into action with the staff that is already in place working with this community. So that would be it.
Thank you so much, Maria Fernanda Manzon from Argentina. All right, I see many comments. I'm going to try to summarize. So let's see. First of all, there was appreciation for the good data, which makes your diagnostic very significant. So that's from Musha Galusa. Dr. Iwat Ndayo says he wants to confirm that you've actually been able to do this with 500 words for each section. Can you just say yes or no to that one?
I actually did. I was putting the number of words before every stage. 493, I guess, was the maximum. But yes.
That was indicative, but it's impressive if you've been able to Mehari Mbao says it's so impressive a presentation, and Mehari does have one question. So let's go to Mehari. Mehari, what is the question you have for Maria? Mehari, your microphone is unmuted. So Mehari asked, I have one question: how vaccination coverage in your scenario over 90% affects vaccination status of children or provokes missed opportunity because of WHO directive to be safe for develop immunity. The vaccination status of a community should be above or equal to 95%. Are you able to respond to that? I'm not sure I fully understand the question.
I don't understand the question.
Okay. All right. So Mehari is not responding, so unfortunately we won't be able to hear back from him. Let's start with Mudo. Mudo, what is your feedback? Maria now has until Friday. She has the feedback from her peers, which she received at midnight, so she may not have gone through it yet.
No.
And so it's important to also get your feedback from WHO and as part of the course team, Mudo, to help Maria identify specific things that she could be able to improve by Friday. Mudo, and then Francine.
Thank you, Rita. I mean, my first feedback is much more, to congratulate her for this great work, and also the detailed background she presented for the case. I think it is an illustration of how relying on, previous studies on the setting you are working on is important to set up some kind of background against which you can evaluate the action plan you will undertake, right? You have here more detailed data about the previous coverage rate in this area, which allows you to know at least where we are coming from, despite the current challenges. And after your design intervention, to have a benchmark to evaluate. And I think this is like a great approach that I encourage everyone to take. Sometimes you have a lot of knowledge about the current context, but it is always good to have some kind of retrospective. The data might not be current or the knowledge as well, but it provide you a solid background and a general background about the setting you are studying. And I encourage everyone to take this approach. Maybe that might be the general feedback I would give. And thank you again, Maria, for this.
Thank you very much.
Thank you so much.
Mudo,
Thanks.
Francine Ganter-Restrepo, over to you. You said already in the chat, I'd love to see how you've made full use of the behavioral and social driver framework and diagnosed the different drivers and barriers, practical issues, thinking and feeling, etc. Tell us more.
Yes, that's. I was just really impressed, and I think this is a great example of what I was saying earlier. The stronger the diagnosis, the easier the subsequent steps become. And I also really love to see that you're proposing a multi-pronged intervention, right? You're engaging not only the parents, but also the health workers. That's really fantastic to see. And the evidence is really that these multi-component interventions do tend to be more successful. So that's really great. Along those lines, I wanted to say that your finding about the previous initiatives to offer powdered milk, for example, were a strong incentive for people to present for vaccination. And I wondered if you had considered that as a lever in your intervention at all. So this is something, for example, we've seen in Botswana at the sort of municipality level. They offer food and water rations in poorer or more remote districts. And this acts as a really strong incentive for people to present at the clinic. And while they're there, take advantage to get the children vaccinated. So I think, again, just thinking about how you use that driver, that motivator for people to come in to your advantage. That's a really critical finding. I also, just a point of clarification, because I was a little confused early on. There was in one slide a note about vaccination being mandatory, but then later on it sounded like it wasn't mandatory, and that was a kind of a rationale for why people were not presenting. So just to my recommendation would be to offer added clarity around that, acknowledging that you don't have a lot of words left to use, but really well done, fantastic work there, Maria. I'm really excited to see.
Thank you so much. Thanks.
All right, wonderful. Thank you very much indeed. Our next presenter is Chidinma Amuzie. So Chidinma, all right, if you'd like to share your screen. And again, I encourage you to focus on really the specific questions that we asked about diagnosis, design, implement, evaluate. Yes, it looks like you've started screen sharing. I'm not seeing your screen yet. Chidinma, you may have to click something to confirm before your screen is actually being shared. I don't know if that's the case. Charlotte, is that the case for you as well?
Yeah, it just indicates she started screen sharing, but we can't see. Probably when connectivity is not too good, it takes a little bit of time for the screen to become visible.
All right. Chidinma, we're not able. Are you able to speak? Okay, so it looks like Chidinma is having an issue with screen sharing, probably with bandwidth. Oops.
Oh, we finally got her screen.
And she dropped off the call. Okay, let's go to Bridget Anim. And of course, please raise your hand to be added to the list of presenters. We will get to as many people as we can in today's session. 90 minutes total. Bridget,
okay.
Are you able
Good
to?
morning. Am I still? Is Chidinma?
Chidinma is back there. Yeah.
Okay, great. Chidinma, go ahead, try sharing your screen again. If your bandwidth, if your connectivity does not hold up, we will move to the next presenter, but let's give it a try. Go ahead, Chidinma.
Okay, thank you.
All right, and here it again says has started. Okay, here. All right, so I'm starting the 5-minute countdown. The floor is yours.
Okay. Okay, good morning, everyone. I'm Dr. Amuzie Chidinma this morning. So actually my title was the poor uptake of COVID-19 vaccines and boosters among the healthcare workers in Federal Medical Center, Umuahia, Abia State. So healthcare workers are those who directly or indirectly deliver care and services to people that are sick and ailing. So in my facility, we have a number of them, as you can see in the work. These include the doctors, nurses, all through to the other allied health professionals. And they are actually predisposed to these infectious agents within their hazardous environments. And of course, data has shown an increase in COVID-19 positivity rates and even deaths among healthcare workers. And according to WHO, healthcare workers are actually the most valuable resource for health. So it's very important that they are prioritized, that their health are prioritized. And particularly for the vaccine uptake, we are prioritized as a frontline. They are part of those prioritized as the frontline workers, okay, giving care to people that are sick. But eventually and sadly, the uptake is very, very low among them. And in fact, a study that was conducted in the Southeast Nigeria, precisely in Abia State, actually gave us a vaccine hesitancy rate of 50.4 among these healthcare workers. And even presently, in my facility, less than 10% of these healthcare workers are fully vaccinated. And of course, out of this proportion, only 21% of them have received their booster doses. So some of the barriers to the uptake of this vaccine and their boosters have been categorized using the BSD framework. And under the domain of thinking and feeling, actually, they are very concerned about the post-vaccination side effects, the efficacy, and even the information and mistrust among the government and the pharmaceutical companies. And of course, for the booster doses, people who had bad experience with the previous vaccination don't opt in for the booster doses. Additionally, even people that were previously infected are likely to, reject the booster doses due to the misconception of natural immunity, following the illness. And of course, some of these have been published in some literature, as we can see the references cited. And then for the social issue, some of these staff deterred, especially the senior staff, deterred their colleagues from receiving the vaccines. Okay, and most times, the staff actually adhere to such advice, especially when it's coming from a senior staff in the clinical category of worker. And then for motivation, most of them don't have the intention to be vaccinated or even complete their doses and get their boosters. Then under the practical issues, there are concerns of unavailability of preferred vaccines. So most times they have in mind a particular one they want to use for their boosters, and maybe when they come down here, it's not available, or according to the ones they have used for the first vaccination, then they're likely to tell them, okay, this is not what is suitable for you, but no, they actually have a preferred vaccine that they feel is more potent and even more active. And of course, these are people that are busy in their various workplace. So they come to work, they are busy till the work time is over, and they may not have the time to even come to the facility. And most times too, for the boosters, they don't even know the particular dates, or whether they might forget the particular dates that is due for them to come for their boosters. And again, most of these barriers have been published in literature. So some initiatives have been taken to increase the uptake of vaccines and boosters. Okay, and these include conduction of research, to determine the rate and even to determine the proportion, and subsequently this was followed up by health education, a lot of campaign, and sensitization to increase the awareness of the benefits of vaccination. Okay. And of course, in the research publication which we have talked about, some of the findings in that study we are shared with the stakeholders, okay, in form of presentation to inform them of the administrative policies that needed to be set up within the hospital. And of course, efforts have been made to create awareness of the existence of some, effective messages that are delivered by some trusted messengers, especially the NCDC and WHO. And even there's some fringe benefits even attached to them, like free data being given to them by accessing such websites. However, there is still an information gap concerning the non-uptake of the vaccine and even the presence of this amid the vaccines.
Apologies, Chidinma, we're at the 5-minute mark. We're exceptionally going to allow you to continue, but please be concise and get to the point to summarize the remaining parts of your plan. Thank you.
Okay, thank you very much. So my design objective is for the health workers in Federal Medical Center Umuahia to change to non-uptake of COVID-19 vaccines and boosters to adoption of these vaccines and the boosters by addressing the barriers known to hinder these processes. So under the thinking and feeling motivation, some of the interventions crafted out from there includes the campaign to intensify messages to address, the trust and misinformation and all that. And then also dialogue-based intervention, so on a one-on-one counseling, in order to curb most conspiracy theories and also the means of information they have within the context of an individual. And of course, we are proposing the use of vaccination reminders through either call or messages, to remind them of their next time for their booster doses. And also, we are also thinking about creating an ease of access by creating time out of the work schedule for people to go for their jobs within the hospital premises. And of course, trying to tell them to use the use of vaccine champions in order to encourage other people to access the vaccines and all that. So based on this, we are actually, this is my implementation. So under implementation, using the good enough approaches, we chose that this will be field tested. So we actually chose to go on establishing health awareness campaign, targeting the healthcare workers on the benefits and safety of COVID-19. So as you can see, the activities there include, holding meeting with the administrative head of hospital, and everything here is how we're going to measure the progress, those responsible, the location, and even the timeline are, shown here. And of course, developing IEC materials that will be shared to the end users, and of course, developing the content that will be used for the health sensitization, the training of the volunteers for this sensitization, and actually carrying out this sensitization campaign. Then this is my second intervention, the dialogue-based intervention, okay, with the roadmap as seen. And then for my evaluation, of course, my quality of data will be assessed by always, supervising the work and also looking on before, as in checking the data daily to be sure that there are no duplicates or inconsistency. And of course, information gotten here will be used to, will be used for action and may suggest scaling up or making more adjustments to the intervention. So this, my evaluation plan, of course, we'll be measuring our input, our outputs, our outcome, and of course, our overall impact, which will be improving the uptake of COVID-19 vaccines and their boosters. So these are some of my indicators here. So for my peer review, one of my feedback included, putting in the number of people, the proportion of healthcare workers actually vaccinated and boosted. So I would need to add it here to, make it more robust. Thank you very much.
Thank you very much indeed, Chidinma Amuzie, for this presentation. Let's see. So there are definitely some comments here from Francine. So we'll go to her so she can say them directly. Dr. Iwat Ndayo says, great diagnosis. Looking forward to your design and roadmap, is probably because Dr. Iwat was conscious you were using up your time. Also says, I've responded to the concern about the word count. So it's an indicative word count. You can have 500 words that say absolutely nothing. You can have 500 words that say something but not enough. And you can have 1,000 words that still say nothing, and they're not useful, to be a little bit harsh. So it's up to you and to your peer reviewers to also give you feedback about the length. Obviously, you write more, your peer reviewers that are short on time, just like you are, because they're full-time professionals, may not give it as much attention as if you pay attention and try to be concise and get to the point in your in your writing. That's a general consideration. Let's go to Francine and then Mudo for comments and feedback on on this presentation. And then our next presenter will be Bridget Anim. Please raise your hand. You can see we have time today. This entire session is dedicated to your presentations and discussions of them. Francine? All right, let me see if we can go to Mudo then. Francine is not.
Oh, yes. Thank you for this presentation. I just had a few questions for clarifying. Are you focusing on a specific health district or I mean, I was not clear about that. And also, I saw that you are talking you're talking about 50% of vaccine hesitancy rate. What do you mean about that? Could you be more specific about what do we define here as hesitancy, or how it is defined in the study? And what I see also interesting is that if it is 50% of the health workers that do not want to get vaccinated according to the survey, and you see 10% coverage. Here, what is interesting is that you see that there is at least 40% missing here. Like the motivation that is declared by health workers is far from what the coverage actually, meaning that apart from hesitancy, there might be barriers, right? Motivation is far higher than coverage, and it might be interesting for you as well to explore this. What are those barriers impeding those health workers that want to get the vaccine but that do not get it according to the survey? Over.
Thank you, Mudo. So two specific questions and one really interesting point. Chidinma, so first of all, can you be more specific about the target population and the site? Is it a district? Is it a facility? What are you focusing on exactly? And then clarify you said 50% vaccine hesitancy rate. How are you defining vaccine hesitancy? And then the third question is, have you explored this gap between motivation, say that there's some hesitancy, and the actual coverage, which is far lower, 20%, you said. So Chidinma, are you able to respond to 1, 2, or 3 of these points and questions?
Okay, yes, thank you very much, Mr. Francis. So my action plan is actually targeting the healthcare workers in the facility where I do work, and that is the Federal Medical Center. However, the survey was done at the state level. It was an Abia state, of which my facility was also one of the study sites. So actually, we are generalizing, or rather, I'm actually generalizing the findings of this study to people in the facility where I work. But my action plan is actually concentrating on the people where I work. And of course, there are room for scaling up as time comes. So, and then for the vaccine hesitancy now, actually we measured it by including people who gave outright refusal to the vaccine. And of course, people who weren't sure that who were unsure of actually receiving this vaccine. And this study was done before the vaccines came in, as in before we started vaccinating. That was sometime last year. That was when this study was done. Thank you.
Okay, all right, thank you. Conscious of the time, we're almost at the top of the hour, then we'll have 30 minutes remaining. Really, we're focusing on your presentations, and this is critical to get feedback from WHO and from WHO subject matter experts, because you now have until Friday to finish your plan. And finishing means, just to review this a little bit before we hear from Bridget Anim and her presentation, you should still be able to see my screen. First of all, attendance in this session is required for certification. Second, you are being asked to present your action plan and share what you learned by performing peer review. Third, your plans and peer reviews will be verified before the decision is made with respect to certification. And then your final task this week is to use the peer review feedback together with everything else you learned throughout the course, including the feedback you're receiving today from your peers, as well as Francine and Mudo from WHO, to improve your action plan The improved version of your action plan is due Friday. Now, we always have a couple of people who submit exactly the same thing and don't make any improvements. Unfortunately, doing that will disqualify you from certification. So make sure that you make significant, substantive, substantial changes to reflect what you've learned between when you submitted your draft and after going through the peer review process and so on. All right, that's it for the update. And then the other thing, Bridget, warm welcome to you. I'm asking you to unmute. You are sharing your screen, but right now we're only seeing file directory. So I don't think you have opened your action plan yet. Let's work out. Are you there? Are you able to speak to us? Okay, I'm not hearing you, Bridget, so I'm going to stop your screen sharing because it seems you're having a bandwidth issue. And unless you respond at least in the chat, we'll go to Shamsu. Okay, who is gone from the room. So we have two, let's see, we have two hopes, two hope Igbo Nagwam. I'm asking you both to unmute. I'm guessing you're using two different devices, which is a smart thing to do. So keep in mind the specific questions. Keep in mind that you only have 5 minutes. Which is why we narrowed it down to these questions. Hope, are you able to hear me?
Yes, I can hear you. Good morning, everybody.
Okay, you sound really far away. Can you come closer to your microphone and speak very loud, as if you were presenting to a you know, in an auditorium or in a big room?
Can you hear me now?
Yes. Yeah, so please, the next step is to share your screen, if you're able to do that.
I am. Okay, can you see my screen?
No, we cannot. So there's probably a window asking you to confirm or asking you which window exactly you want to share. So look for that. Otherwise, it is fine if you want to take on the 5 questions without sharing your screen. That's okay too.
I can share my screen.
And so,
is this better? Can you see it now?
no, still no screen, no screen shared. I suggest you go ahead and, okay, here we go. You've started screen sharing.
Yeah. Okay, can you see my screen now?
Yes, we can. So the floor is yours. You have 5 minutes.
Okay.
Please do your best. If you go over time, we'll probably allow it, but that means less time for your colleagues to present.
Okay, no, I'll try to be specific. Okay, my topic was on poor coverage of Penta-3 vaccination among under-1 target population in Imo State, Nigeria. So to make a diagnosis, I hope I'm not echoing.
No, you're coming in loud and clear.
Okay. So on the 1 target population, which make up about 4% of the total population, should at least have 85% of routine immunization coverage, especially at attaining the pentavalent and oral polio virus vaccine. So in my state, we found out that using, you can see a graph I made, between January to September this year, the coverage rate of the entire state is 65%, which is less than the coverage, expected coverage. So you find out that those on red are those that didn't meet up with the expected coverage rates of under 1. So just 7 out of the 27 local governments met the 85% target coverage rate, which is approximately approximately 1/4 of the local governments in the state. So that poses a concern. So if people didn't come for Penta-3 vaccine, it means they actually missed other vaccines, such as OPV3 and even rotavirus vaccine that is being given at the same time. So this poses a concern. Even PCV that are being given at the same time. So there would now be a high incidence of vaccine preventable diseases of all the 5 vaccines, that's the penta vaccines. So, and even high incidence of AFP, just like we're having some outbreak of high incidence of CVP 2 vaccine. So that was the diagnosis I made. So just take it to the designs. So how can this be converted? So from the feedback I got yesterday, I wasn't able to specify diagnosis, design, so I put everything together. So it made my peer reviewers to have some difficulty. So I'm really going to make it concise when I'll work on the feedback. So one of the things I designed to do was community engagement, intensify supportive surveillance of routine immunization, sensitization of mothers and caregivers, because we actually found out that most of these local governments where these things are persistent are those where there are so many scattered or isolated settlements, and where there are poor access to health facilities. And you know, people have to walk for a long distance to access care. So due to security challenges, they say, let me don't walk to that distance because I stand a chance of being kidnapped or killed. So we now designed, from my action point, I designed some points, apart from telling them and explaining to them, other ways to combat this is, you know, to address the security challenges, then the accessibility. So the increase, talking to health workers, because health workers also have apathy because of non-payment of salary. So most of them don't come to work. So sensitizing the health workers to be more intentional in what they do was part of my design, so that they are going to do more of outreach section that's taking the vaccine to meet the end users rather than the other way around, expecting them to come to them. Then also, you know, the leadership governance thing, to talk to any way we can to intervene, to talk to governments to ensure that these workers are being paid their salary, because some of them are being owed for 2 years. So that causes increased apathy among health workers. And some of them has retired and don't come to work, and they are not employing new workers. So that actually increased workload, and some of them, because of increased workload, non-payments, it now creates a gap, like creating a poor attitude to work among health workers. So this has actually affected access and utilization of vaccines. So these are my designs. I mentioned them: increased sensitization, community engagement. You involve the community. Like some of them actually, in my review, in my one of my peer review actually told me that I should also consider involving, that's training the religious
Hope you
leaders.
are out of time. I'm going to ask you, out of respect for your colleagues who are also waiting to present, if you could be concise and summarize the rest of your, and I encourage presenters, think about, you know, don't spend all your time on diagnosis or design, but really think about the 5 specific questions that we've asked. Thank you. We'll allow you some additional time at the expense of your colleagues' time, unfortunately.
Okay, so among the interventions, indicator, I picked immunization coverage. So the purpose is to assess the immunization coverage for a specific age. Then, okay, for the short term is to find out if there are micro plan available to ensure that every ward is being reached. Then the frequency was weekly. So how we're going to do that is weekly data collection to know if the expected target population was met at every section. Then about completeness and timeliness is to ensure that everything is done completely and timely. Then number of unimmunized patients is to find out if you find out if the expected number was vaccinated, you'll be able to know the number of unimmunized. So you check out the dropout rates using the monitoring charts. You'll be able to find out those that came for Penta 1 or Penta 2 that didn't make it for Penta 3, what happened. And using the community, village community mobilizers or what developmental community you'll be able to reach those ones and ensure that they are being immunized. So I had to just brush it up. So I can take those specific questions.
Thank you, Hope. Let's go. All right, I don't see any comments specifically about this presentation. So colleagues, obviously Hope has put significant effort into this work. Please honor her work as you would like others to honor the work and the effort you've put in by sharing your comments in the chat. We'll go to Mudo and then Francine, who I believe is having connectivity issues, but let's at least try. Mudo. What would be your advice and guidance to Hope, knowing that by Friday her task is to significantly improve and strengthen the initial draft of the action plan, and she will of course benefit from the inputs from her peers through the peer reviews. But would be lovely to get some specific advice from you and Francine if you're able to speak. I'm asking you both to unmute.
Thank you, and thank you for this presentation. Maybe just a quick feedback would be to get more structure in your work. I mean, it might be good to go back to the base framework and to match the different dimensions, right? What is related to thinking and feeling, what is related to social norm, to motivation, to practical barriers. Here, it seems that you are focusing a lot on some practical barriers, right? But it might be good to assess, to have a more comprehensive assessment. And also one question I have for you is about, I see that there is a lot of heterogeneity in the coverage rate across the different locations. I think you presented, and it is interesting, right, to see that there are some locations that are doing very well, and others that are far from the target, the 85%. One question I have is, do you think that it is structural? I mean, is it a structural factors or something related to much more the crisis? I mean, the COVID-19 pandemic, for instance. Is it an area where the coverage have been always low, or is it something much more connected to the pandemic? It might be also interesting to have some perspective on that, because it might guide you on the type of solutions that you should think about, if it is more structural or is it something much more related to COVID-19, given that they are performing lower than the others or over.
Thank you, Mudo. Francine, additional comments or thoughts? I know you're having, I believe you're on the move. Yeah.
I'm trying again. Let's see if this works.
Great. Yeah.
Thank you so much for that presentation. I want to first of all say I love how you're approaching this at different levels of the health system, right? So you're, really thinking about what's happening in the communities, what's happening with the individual health workers, but also what's happening in the policy space at the government level. I have to say that when it comes to that area, unfortunately, it can be a little trickier to have to have impact, but I really like how you're approaching this from several levels. I think to take your action plan to the next level, what I would recommend is really thinking how you're going to structure these different interventions, what's going to come first, and what order are you planning to do things, and really with your indicators, make sure that they're very concrete and measurable. So that it will facilitate really understanding that you've had the impact that you intended to have. But really want to thank you so much for that great presentation. And as I said, really applaud you for thinking about this, not just at the community level, but also what's happening across the health system. That's very interesting to see. Thank you.
Thank you, Francine and Mudo. Now we are at the 14-minute mark. We have 16 minutes left. So what I suggest is we're going to hear first from patients, then from Sebenzile Shezi. I remember Sebenzile on day one of the course, who explained that this is the first time she was taking a course with the Geneva Learning Foundation. So looking forward to that presentation as a first-time scholar. And I hope soon to be alumna of the program. So, but first, Patience, over to you. You have 5 minutes. Please keep in mind the specific questions and do not spend, my advice is don't spend too much time on the first sections. Give us an overview. What was your priority group? What knowledge gaps did you identify? What are the top drivers and barriers to vaccination for this group? And then move on to design, implement, evaluate, so we get the full picture. Over to you. You have 5 minutes.
Okay, thank you. My name is Patience Ofosuhima. I'm in Ghana. I work with the Ghana Health Service, the Health Promotion Division. And I am the focal person for persons with disability when it comes to project. Okay, so my priority group is the deaf community in Ghana. Sorry, there was the deaf community in Ghana. So about their background, it is they form under an association called Ghana National Association for the Deaf. It was established in the year 1968. It's part of the Ghana Disability Council and also part of Deaf Federation. The HATIT members are about 11,000 members. That is 60 to 40, that is men and women respectively. And then out of this 110,625 deaf people in Ghana, I'm supposed to get a data of vaccinated and unvaccinated people among this particular group, which I think even the reviewer even made mention of it, which I will add up when I'm reviewing. The challenge, why the challenge is so present. Most service providers are unable to communicate using the sign language interpretation. And then we don't have enough SBCC material to support activities of the set target group to uptake vaccination. I mean, COVID-19. I also need to be specific on a particular vaccination I'm talking about, so I'll also update that when I'm reviewing. Specific barrier or today's priority group, their major challenges is communication barrier. They mistrust products. If service providers are unable to explain thoroughly how it works, they are concerned with the side effects and rumors. What has been done? From the beginning of the pandemic, Ghana Health Service, the Health Promotion Division, had engagement with the association, which they trained some of the sign language interpreters to help us send message across the deaf community. What is needed? We need audiovisuals with sign language interpretation and subtitles, information on vaccines uptake. Then to train more sign language interpreters to facilitate mass education and trainings and intensive community engagement by Ghana Health Service and stakeholders on vaccine uptake. Then major funding to support HPD in producing mass social behavioral change materials to support campaign, especially Braille for vaccine uptake for the deaf blind community. Identification of gaps. If there are influencers, we might use them, but currently I haven't come across an influencer among this particular people who might help us to engage them. Communication barrier, inadequate sign language interpreters to carry out information on vaccine uptake to the deaf communities, inadequate SBCC material to support activities of the set target group for the uptake of COVID-19 vaccines. Design. Communication strategies need to be specific to key concerns. And of this target priority group, the following are factors that can facilitate uptake. More sign language interpreters and scientific medical information from experts. Confidence in vaccine uptake, safety and efficacy, and in service providers through intensive education and engagement. Mass production of SBCC material to support campaign of the said priority groups. Factors that can leverage. More sign language interpreters and scientific medical information from experts is being explained here, or are here. Because of time, I will skip. I've made mention of that. So the main objective is for the deaf community to change from unvaccinated people to vaccines uptake ambassadors by addressing inadequate of sign language interpreters, confidence in vaccine safety and efficacy, and in service providers through intensive education, community engagement, and inadequate SBCC material support activities of the deaf to uptake vaccination, leveraging mass production of all that have been listed above. So, and the end user partner, a persona, I use anonymous person called Patricia. She's a deaf person, and then she got the disease around 3 years. So mostly for the thinking, she believes that if able community are even rejecting the vaccines, why should he, who is already ill, like vulnerable, they think they are vulnerable, so he can't go for the vaccines. Her social support is her husband, because the husband is also deaf. Most of the extended family can't also do the sign language for him. And then his motivation also comes from the husband as well. So I think if he's able to get access to all the needs, she might make a move. And practical, in the community she lives in, there is a health facility. So if she's able to overcome all this, I think Patricia will go for the vaccines. So the end result, unwillingness to vaccination to vaccine uptake ambassador. Implementation plan. The plan, the goal is to promote vaccine uptake among persons with deafness in Ghana. So objective is increase adoption, vaccine uptake among persons with deafness in Ghana, to provide training for Ghana members on misinformation, disinformation, rumors and misconception across the country, to break the communication gap with deafness and service providers by training more sign language interpreters. Work plan. I have an input here. It's just an illustration. So how activities will be the objective. 1, deaf people are well informed. So I have increased vaccine uptake among deaf persons in Ghana. Then I'll break it down to how it will be implemented. Among some of the activities that will be implemented to achieve these objectives, we will conduct baseline and end-line assessment of vaccine uptake among persons with deafness. We will develop SBCC materials on vaccine uptake, educate, demonstrate kits for deaf persons for vaccine uptake, and also conduct community knowledge on vaccine uptake. 2, strategic training for Ghana members. These are some of the activities that will be implemented. Develop or adapt a manual or guidelines for vaccines uptake in Ghana. Majority of health promotion officers and Ghana National Association for the Deaf members receive training as scheduled. Objective 3, to break communication barrier. These are some of the implementation. Build capacity of Ghana National Association for the Deaf coordinators and healthcare providers on IPC to be able to use vaccine uptake and SBCC materials. To train health promotion officers, coordinators, and healthcare providers on how to sign and guidelines for vaccines uptake in their communities. Development of data capture tools. Conduct quarterly monitoring and supervisory. We conduct review meetings, quarterly final reports, and documentation.
I'm going to have to interrupt you.
Okay.
Patience. Thank you so much for this presentation. I really want to hear at least one more presenter. And again, perhaps we weren't clear enough ahead of this session, but really the intent was to have short summaries rather than walking through the entire presentation. Okay. But that's probably our responsibility if that wasn't clear to presenters. Thank you so much. I wish we could hear this full presentation. I know that it generated your focus on people with disabilities. You generated a lot of interest. So really want to appreciate. And then there's some great feedback in writing in the chat from Francine Ganto-Restrepo. Now, our last presenter for today will be Sebenzile Shezi. Sebenzile.
Thank you.
Please go ahead. Are you able to share your screen? Sebenzile, are you able to share your screen, please? Yes. Okay. And now you need to unmute your microphone. And all right. And again, you have 5 minutes. I understand it's difficult to do it with no advance notice, no preparation, to really synthesize, to summarize what you've done, which is why this morning we shared the 5 specific questions to consider. The floor is yours. We'll have probably 2 minutes for Francine and Mudo to conclude. Over to you.
Thank you so much, guys. This is Sebenzile Shezi. Pardon me with my voice. I have a bad flu. So this is the action plan. My topic, come on, can't move. Okay. Fine. So as the action plan to address the low uptake of COVID-19 in the age 12 to 24 years. So it's these two different categories. It's 12 to 17 and 18 to 34 years. I went ahead with defining my priority group. That's this age category is one who spend most of their time with their peers, and they are very misinformed. They spread rumors fast and easily, and they laugh at each other, make fun of themselves, of the one who are taking the vaccine. And their concerns around the fertility, they have the means that it affects their fertility as well. This is a group that is very concerned with their body images. So the myths around COVID-18 then make them their body changes, so they then hesitate to take the vaccine. They are also afraid of taking needles, especially if they are not sick. It's not the group that will just easily go to the facility, to the clinic, and then take a vaccine. They're not as well, don't want to attend health facilities, as I've said, if they're not well, because they have a poor relationship with the health workers at the facilities because of the long queues they have to wait. And the youth has an attitude that the nurses and the healthcare workers are judging them. So they don't have that relationship with the health facilities. Involvement can support and listen in their content, can assist when then buying into your products. Okay, so I've continued in my diagnosis to elaborate with the statistics with where we are as South Africa, especially the KZN province where I am. We are not doing good in this category. We are at 45%. So one of my reviewers also, because I've included all the age categories according to the statistics, they said I must just concentrate, because one other aspect I've increased, I've went over 500 words that is required. So I should concentrate to the age category that is targeted. So currently, the age category 18 to 34, we are at 32%, and the one which is 12 to 17, we are at 35. So the intention is to increase that into an coverage of 70%. So this is a graph that tells you the national coverage of COVID-19 in all age groups, and also this one across the provinces around the country, the KZN. So here is the age category 18 to 34. That's what we are in terms of the statistics that I've mentioned above. It's
1
also
minute
in the graph.
remaining.
Okay, so let me go to diagnosis. Yeah. So all the questions on the rubric we answered today. The design, main goal is to achieve of this action plan is to increase the coverage, COVID vaccine coverage from 38 to 70 in the age 12 to 17, and 33% in the age 18 to 34. The objectives aimed at changing our teenagers, young adults, and healthcare workers from the following behavior. They are from having the vaccine hesitancy with ongoing means, and being influenced by social media, as well as that they change from not attending the health facility due to long waiting time, and they also benefit from the COVID-19 to the behavior that is positively opposites to that one. So the activities and the action around that will be taken is to coordinate and plan multi-sectoral and community engagement to get their buy-ins on the vaccination program. There is the involvement of the local stakeholders, social development, Department of Education, social development, and municipality. Then our facility to organize themselves in order to ensure that people get the care they need when they need it in a way that is user-friendly. In that way, it will assist with us by these target groups attending or coming into our facilities.
Thank you very much, Samantha. I realize you did not make it to the end, but nevertheless, for you and all the other presenters, I want to once again share with you what we would be doing, I think, if we were in a physical room together. So a lot of effort and hopefully progress. Now, this is a milestone, listening to these presentations, receiving feedback from WHO. You have now until Friday to go back and improve your plan. I do want to share, and again, the names of the 55 scholars who submitted an action plan and completed 3 peer reviews. Now, we'll be checking your work, so this does not mean you've earned certification. There's several steps remaining in order to finish the course. You can see them here. Attendance in this session is required for certification. You've been asked to present your action plan. That is not a certification requirement, so if you did not present, doesn't mean you'll be disqualified. Your final task this week is to use everything you've learned so far and go back to your action plan and make your significant, substantive, substantial improvements and submit that improved version. Now, we always have 1 or 2 people who submit exactly the same thing they submitted the first time. Unfortunately, that immediately disqualifies you from certification. So even if your first plan was near perfection, you should have identified specific things you can improve going forward. I know we are now over time. I do want to go to Francine and Mudo. This was their first participation. They're also first-timers in the scholar course using this accelerated itch format. Would be lovely to hear parting words from Francine and Mudo before we close. Let's start with Francine, if you're able to. Let me asking them to unmute. Yes, Francine.
Yes. Oh, thank you, Reda, and thank you so much to all the scholars with us today. Everyone who was brave enough to present and share your work with us. I just really want to congratulate you all, and even those who didn't present. I know you've been working hard. I've seen what the course schedule is like. So I just want to say well done to all of you. I know a lot of this content is new, and for many of us working in immunization, this could be a really innovative way to think about how we organize vaccination services and programs. But from what I've seen, you're really just you're walking the talk. You've just jumped right in there and really appreciated this idea of putting people first, putting the health workers, putting the communities first, and really considering their perspectives and needs, and how we leverage that to increase uptake. So well done, all of you, and well done, Charlotte and Reda, for carrying this through. Thank you.
Thank you, Francine. Mudo, final thoughts and words for this cohort and about your first time experience of this itch methodology.
Yeah, thank you very much, Reda. I would like also, as Francine, to acknowledge the great work that you have done, and all the participants over all this month preparing the course, but also during the course. And we have been, I have been also learning. I would like to also express that to the participant. Thank you very much. We have been also learning a lot from your experience, from all the cases you have been presenting. And I think that there is here also material in the future to build upon, right? Having like a summary of the different challenges that you are facing and your experience in addressing them and so on. Maybe this is for the work, but we will consider that building on all the cases you have presented. And finally, maybe I would say that always think about asking the good question. I mean, this is the first step, right? Once you ask the right question, you will have chance to find like the right answers, and so spend a lot of time on this diagnostic part, right? identifying what is really going on. And from this, every single step will be much more easy. So yeah, thank you very much. And thank you, Reda, Charlotte, and everyone.
Thank you very much indeed. So you see on your screen what you need to do to finish this course. So your final task will be to use the peer review feedback together with everything else you learn throughout the course to improve your action plan and submit that improved version. It is due by Friday. You will find in peer grade, you will find the slot where you can submit this improved version. And last but not least, this group is the first one with whom we are sharing under the banner of the Movement for Immunization Agenda 2030, a special event organized with the SP1 working group. So it is strategic priority 1, not 2. But as Charlotte said earlier, it's they're all connected, and this is the sort of umbrella for many others. So this will be for the launch of the IA2030 Immunization for Primary Healthcare Framework for Action, and also an opportunity to share experience with colleagues from all over the world. I believe Charlotte has shared the link to that event. Wishing you well, and again, we have until Friday. There are no more peer support sessions, so you are expected to individually finish this work. Look forward to seeing your final submissions. Don't miss that Friday deadline. Once again, there are no extensions, and this is the final deliverable in the course. If you've made it this far, don't miss this final one. Take care. Now let's have everyone on mute now. Let me just ask you all. Yep, you should see a prompt to unmute so we can actually say goodbye to each other.
Thanks and bye.
Bye, everyone.
Thank you.
Hello everyone, I'm very happy to share this course with you. Thank you.
Last photo.
Nice to be with you.
See
nice
you.
to be with you.
Thank you and bye.
My team leader.
Bye.
Bye.
Hey, I need to see me. Bye.
Bye.
In the photo, please turn on the webcam, and then we'll be
Go, Simo.
ready.
Yeah. Nice to meet you.
Simo, my team leader.
Let's see if I can get
Your team leader. Yo.
Go ahead and please, if you are able to turn on your webcam even for a second, please do that. Love to see you.
Hi, everybody.
All right, lovely to see Maria, Dr. Mudo, Mohammed, Bridget, Dr. Mary, Chika, Nazimo. Please go ahead and turn on your webcams if you can, just for a few seconds, so we can see each other.
Nice meeting everyone.
So my video can come on. I don't know.
Hello.
Hello.
They listed all our names. Thank God.
Bye.
Bye.
Bye. Thank you, everyone.
Okay, lovely to see some of your faces as well. Look forward to sending out the certificates with your names on them. And even more importantly, look forward to hearing back from you about what you do with these plans now that you have developed them. We'll have them by Friday. Take care.
And the last part is
Thank you. Thank you. Thank you.